Hi guys, good evening. Good evening. Yeah, so welcome to our third series of Farre and आज हम discuss करेंगे all the important questions in GIT. ठीक है, तो GIT में we'll start with the questions which are asked in your esophagus and from there we'll build up from there as well. तो क्या क्या questions थे which were asked from esophagus? So esophagus के chapter में जो सवाल आए थे, the question that they were asked was, number one, they've asked you about the tracheoesophageal fistula. They've asked you about the tracheoesophageal fistula. They've asked you about the GERD. They've asked you about Barrett's esophagus. They've asked you about the Barrett's esophagus. They've asked you about the esophageal varices. They've asked you about tips. They've asked you about the causes and the management of upper GI bleed. Upper GI bleed and management. So these are the important questions. Good evening, guys. So what they've asked you is about the tracheoesophageal fistula, GERD, Barrett's esophagus, esophageal varices, that is TIPS, that is a transnuclear intrahepatic portosystemic shunt, upper GI bleed and its management. These were the questions that they've asked you in the exam. The tracheoesophageal fistula and its component that were asked. This was for 10 marks question. GRD was asked for 5 marks, Barrett's was asked for 5 marks, esophageal varices was 10 marks, TIPS was 5 marks, upper GI bleed and management was for 10 marks, right? So this is how the distribution went across. So we'll try to analyze each one of these questions, how to write it. We know the performer. देखो GIT में अगर आपने डायग्राम नहीं बनाया, इसका मतलब है कि आपने GIT अच्छे से नहीं पढ़ी है. As simple as that, right? So the first one that we're going to talk about is going to be your tracheoesophageal fistula. तो पहला आंसर शुरू करते हैं. Just give me a second. Okay. So the first answer that we're going to talk about, it is going to be about the tracheoesophageal fistula. So we'll talk about all the important manifestations of the TOF that you have. This is not tetralogy of Fallet. This is going to be the tracheoesophageal fistula. Just give me a second, guys. Small issue with my pen. One second. Okay. So TF stands for tracheoesophageal fistula. Right. Now, when we talk about the tracheoesophageal fistula, as we said, always start with the definition, then you talk about the pathophysiology, then the clinical presentation, all that. So, यहाँ पे दो definition आपको बताने होंगे. Number one, what is a fistula? So, define fistula. And then you also have to define something called as atresia, right? Now, fistula is defined as an abnormal communication. It is an abnormal communication between two lumens. Between two lumens or a lumen and a cavity, or a lumen and a cavity is what we call it as the fistula. Now what is an atresia? Atresia is defined as incomplete. It is defined as incomplete or improper channelization between two ends of a bowel. Between two ends of the bowel loop, right? So first of all, what is the definition? Fistula is an abnormal communication between two lumens and a lumen and a cavity. Atresia is an incomplete or improper channelization between two lumens, that is two ends of the bowel loops. That's it. Okay? Now, this is your definitions about the fistula as well as atresia. Next, you have to write what is the pathophysiology. what is the pathophysiology? What is the pathophysiology of tracheoesophageal fistula? Now, a quick recap of the pathophysiology is, remember, the esophagus is developed from the foregut. So you can simply draw a small diagram saying that this is the representation of a primitive foregut. Now, from the foregut, as it continues to develop, you will see there's a development of a septa, and this septation will divide the foregut into two lumens. There is an anterior channel and there is a posterior channel. Now, this is the anterior channel of the foregut and this is the posterior channel of the foregut. And between these two, there is this septa that is formed. Usually, this septa is going to differentiate. This is the common channel, that is going to be the cricopharyngeal region, and from here you will see that it is going to branch out into trachea, and posteriorly it is going to continue into esophagus and then into the stomach. As we all know, the foregut is going to derive, or it is going to, the foregut develops all the way to the second part of the duodenum, including the esophagus as well as stomach. It continues to happen so, and this is going to branch out into your respiratory bud, trachea and all that, right? So this is the division. The anterior division is going to develop into the respiratory. So this anterior division, this is also called as the respiratory bud. The anterior division is also what we call it as the respiratory. This is what we call it as the respiratory bud. The posterior one is what we call it as the esophageal bud. It is the esophageal bud, right? So this is the normal development of the respiratory bud and the component here. So the one that is present on the anterior, this is going to become the tracheal tree, that is tracheobronchial tree. This is going to be your tracheobronchial tree, and this happens to be the esophagus. This is going to be esophagus. So what is the pathophysiology? The pathophysiology comes down to this septa, right? So why does a tracheoesophageal fistula develop? So it develops due to incomplete. It is going to happen due to incomplete. It is due to an incomplete or improper septation. So this is because of incomplete or improper septation that is going to result in the development of tracheoesophageal fistula, right? Now, once you now know the different types of the tracheoesophageal fistula, you have to quickly write the types of tracheoesophageal fistula, right? So in the alphabetical order, you have type A variety, you have the type B variety, you have the type C variety, you have the type D variety. Now, in that context, and you have the H variety. Now, what do you mean by all these varieties that you have? Now, in a type A variety, you would notice that the trachea is going to be absolutely fine. There is no problem with the trachea. So trachea branches out exactly as it is anticipated. There is no problem to the trachea per se. Now the problem exists, that is going to be in the esophagus. You see the esophagus fails to channelize. So there is the atresia between the two lumens of the esophagus, and the type A variety is what we call it as the pure atresial form, where there is only atresia. In type B variety, you will see the trachea is going to be absolutely fine, and it is going to branch out into the right and the left main bronchus. That we all know, these are the tracheal rings which are going to be present. So what is here? Now the first thing, you would notice that the atresial segment of the esophagus is attached to this end, and the lower end remains in this way. So here there are two problems. One, the esophagus fails to channelize. Now as the esophagus is failing to channelize, what is that? There is atresia, and then you see the esophagus is communicating with the trachea, that is fistula. So here there is both fistula as well as atresia is present. In type C variety, you will see again everything remains the same. The trachea is at position in its own status. Right main bronchus, left main bronchus division is fine. These are all your tracheal rings which are organized in this form, and then you see esophagus is having atresia, but this time the fistula is formed. This time the fistula is formed from the lower end. This time the fistula is going to be formed from the lower end, and this is your type C variety. So in type A variety there is only atresia, type B variety upper fistula, type C variety there is lower fistula but the atresia is still maintained. In type D variety it is going to have both upper as well as lower. The trachea is fine, there is no problem with the trachea per se, the division is also fine. These are your tracheal rings which are going to be aligned here. All these are fine. This you see there is an atresia which is formed here, and there is an atresia which is formed here as well, and this continues into stomach. Nobody is going to stop it. And then the atresia, right? So there is an atresia, there are two fistulas, both upper and the lower communicating fistula. This is your type D variety. Next comes is our H variety. Now in the H variety, you would notice that this is going to be the trachea that is present. Trachea is absolutely fine. There is no issue with the trachea. It continues to branch out into the left and the right main bronchus. This time, for my surprise, the esophagus is also fine. There is no issue, but you will see there is a small communication between these two. It channelizes, and then this is your stomach, right? So in the H variety, if you notice, there is no atresia, there is only fistula. So H variety is a pure fistula type. It is going to be a pure fistula type, right? What are the role of these varieties? When you have a different component, the presentation is going to vary, right? But you should know these are the possibilities that you have. Now, when you talk about it, remember the type A variety is what we call it as there's only esophageal atresia. There is only esophageal atresia. अगर आप पूछ रहे हो कि इन varieties का क्या यूज है, अभी आपको क्लिनिकल फीचर्स बताएंगे, तब आपको एकदम क्लियर हो जाएगा कि भाई varieties का क्या यूज है. Type B variety, this is the upper esophageal segment, this is the lower esophageal segment. So here there is presence of esophageal atresia. This presence of esophageal atresia with upper esophageal segment fistula. So it is the upper esophagus that is participating in the fistula development. That is a type B variety. Type C में क्या है? Type C में भी same है. You can see the upper esophageal segment is fine. This is the lower esophageal segment which is having a fistulary communication, and there is atresia, right? Atresia is no communication. So here also there is presence of esophageal atresia. There is presence of esophageal atresia with lower esophageal segment fistula. So there is a lower esophageal segment fistula is present. Type D variety, you will see the fistula is present in the upper esophageal segment as well as the lower esophageal segment. So there are a fistula communication between these two. Again, the atresia existed. So here there is presence of esophageal atresia. Then esophageal atresia with both upper esophageal segment and the lower esophageal segment fistula is formed. So it is an esophageal atresia with both upper and the lower esophageal segment fistulas are formed. This is what we call it as the type D variety. The H variety, it is only tracheoesophageal fistula. It is only the tracheoesophageal fistula, right? So here it is a pure fistula form. You will see only the fistulous presentation. There is no atresia. When the baby is going to drink milk, the milk is going to go straight down, right? The milk is going to go straight down. The milk is going to go straight down. So there is no atresia per se. Okay? So clinically talking, remember by incidence, the most common type. The most common type of the tracheoesophageal fistula is a type C variety. It is going to be a type C variety, right? So we discussed the pathophysiology of it. Then we discussed the various varieties of the tracheoesophageal fistula that is going to be found. Now we'll talk about the clinical features, right? So here when we talk about the clinical features, we'll talk about the clinical features of type C tracheoesophageal fistula. TOF stands for tracheoesophageal fistula, right? Now you need to understand that every patient who is going to present to you with tracheoesophageal fistula will have a very predictive component, right? Now when you look at this, The first one is the age of presentation. At what age would you expect these babies? Now in the GIT, the concept is very simple. If there is a frank obstruction, what are the examples of frank obstruction? It could be an atresia, it could be, uh, a frank obstruction basically means there's an absolute cutoff of passage. The best examples are like atresias. But if there are relative obstruction like narrowing or stenosis, example like CHPS, congenital hypertrophic pyloric stenosis, in those conditions there will be a delayed presentation. If a baby has an absolute obstruction, a frank obstruction like atresias, the presentation will be on day 0 or day 1 of life. It is going to be day 0 or day 1 of life. It is going to be on day 0 or day 1 of life. So all babies who are going to have atresial segments or frank obstructional presenters, day 0 or day 1 of life, right? So at what is the sex which is more likely to be affected? Slightly it is more common in male babies when compared to female babies. Whenever you have a doubt now in any congenital disorders, the best answer to pick will be a male baby, because female baby have better survival. So their anomalous component or probability of having anomalies are much lower when compared to male babies, right? Now, so you have a baby who's on day 0, day 1, right? Day 0, day 1, day 0 is the day of the baby is born, the next day is called as day 1 of life. It is more likely to be a male baby. So what will be the presentation? Now, in order to understand the presentation, you have to envision what we're talking about, right? So talking about a type C variety, in a type C variety, you have the trachea, which is here. This is where there will be a fistulous communication present. The upper esophageal segment remains in atresia. The lower esophageal segment is going to communicate with that of the stomach. So what is the clinical presentation that is going to happen? Now, as soon as the baby is born, right, तो जैसे ही बेबी पैदा होगा तो क्या बोलोगे? मुबारक हो, आपको बच्चा हुआ है, ठीक है? तो obviously the mother and the father like, ये बच्चा हुआ है, good. अब बारी है कि ठीक है, बच्चा पैदा तो हो गया, अब तो जिम्मेदारी संभालो, बच्चे को भूख लग रही है, तो भूख लगेगी तो क्या करोगे? खाना खिलाओगे, खाना इसको खिला नहीं सकते तो क्या बोलोगे? दूध पिलाओगे. So the minute the mother starts to feed, तो क्या होगा? The milk will go into the esophagus. अब आगे जाने का रास्ता नहीं है तो क्या होगा? The milk will start pooling in the esophagus. पूरा भर गया तो अब क्या होगा? अब जगह जाने के लिए नहीं है तो क्या होगा? तो वापस पीछे फेंकना पड़ेगा. And that is what is going to happen. Every time the baby is fed, the milk goes into the esophagus. Esophagus में आगे जाने की जगह नहीं है तो वापस बाहर pull in करेगा. And that वापस बाहर pull in करने को क्या बोलते हैं? You call it as repeated. We call it as repeated regurgitation. There is repeated regurgitation of all feeds. Now all feeds का मतलब ये नहीं है कि मैं बेबी को यहाँ पे चिकन बिरयानी खिला रहा हूँ, ठीक है? All feeds का मतलब है कि every single time the baby is fed, there is no way that it can go anything further. तो ये बाहर आएगा. तो पहला बोलेगी अयो जब भी पिला रही हूँ, अरे ये तो पूरा दूध वापस निकाल दे रहा है. तो first concern. Now another very interesting thing is, क्योंकि बेबी अभी बॉर्न है तो ऑब्वियसली नियोटोलॉजिस्ट इज गोइंग टू कम लुक एट इट. तो 2-3 चीजें और देखने को मिलेगी. देखो, बेबीज प्रोड्यूस मोर अमाउंट ऑफ सलाइवा पर यूनिट सरफेस एरिया व्हेन कंपेयर्ड टू एडल्ट. तो ऑल दैट सलाइवा, व्हाट इज गोइंग टू हैपन? जो भी सलाइवा बनेगा ना, नॉर्मली दैट सलाइवा शुड हैव गॉन इनटू द इसोफेगस. फ्रॉम द इसोफेगस वुड हैव गॉन इनटू द स्टमक. इट वुड हैव रिवर्टेड आउट. लेकिन अब यहाँ जगह ही नहीं है तो क्या होगा? पूरा सलाइवा फ्रॉथ करते हुए बाहर निकलना शुरू होगा. So you'll now notice that because there is no other space for the saliva to go in, it will start drooling out of the mouth. तो ये बेबी को जब आप देखोगे ना तो ऐसा लगेगा कि बेबी आपको देख के लाल टपका रहा है, आपको देख के नहीं टपका रहा है. बेबी को आगे सलाइवा जाने की जगह नहीं है, इसलिए बाहर आ रहा है. तो there is repeated region of all feet. There is continuous drooling of saliva. ठीक है? तो 2 प्रॉब्लम्स हो गए. एक आपका हो गया रिपीटेड रिजेक्शन ऑफ ऑल फीड्स एंड देयर इज कॉन्टिन्यूस ड्रूलिंग ऑफ सलाइवा. अब देखो, अब सलाइवा जब वापस आ रहा है, इट इज नॉट नेसेसरी दैट इट विल ओनली कम इनटू द माउथ. सम अमाउंट ऑफ सलाइवा और सम अमाउंट ऑफ फूड जो भी हुआ होगा can also go into the trachea. Now as it goes into the trachea, it will irritate the trachea. That is nothing but aspiration. जब tracheal irritation होगा तो क्या होगा? There will be coughing and cyanosis. This baby will have frequent coughing and cyanosis, and this worsens on feeding. दिस वर्सन्स ऑन फीडिंग, क्योंकि फीड करने के बाद देखो सलाइवा से ज़्यादा इरिटेंट तो दूध होगा, और वो मिल्क जब वापस आके ट्रेकियल सरफेस पे गिरेगा इट विल कॉज मोर इरिटेशन एंड दैट इरिटेशन विल कॉज कॉफिंग एंड साइनोसिस ड्यूरिंग फीडिंग। अब मम्मी बोलती है बेटे को कुछ प्रॉब्लम है, डॉक्टर साहब को बुलाओ, डॉक्टर साहब को बुलाओ, और डॉक्टर साहब आ गए, ठीक है। अब डॉक्टर साहब बोलेंगे ठीक है काम करते हैं, देख लेते हैं, ठीक है। तो एक तो हो गया रिपीटेड रिजेक्शन ऑफ ऑल फीड्स है, कॉन्टिन्यूस ड्रूलिंग ऑफ सलाइवा है, कॉफिंग एंड साइनोसिस ड्यूरिंग फीडिंग है। तो ये तीनों चीजें मुझे क्या बता रही हैं, ये बता रही हैं कि दी पैसेज आगे जा, देखो ना ही सलाइवा जा पा रहा है ना ही दूध जा पा रहा है, तो कुछ तो जाने का रास्ता ब्लॉक पड़ा हुआ है, ठीक है। नाउ व्हाट आई एम गोइंग टू डू, as soon as you have a day 0 day 1 baby where there is repeated region of all feeds, continuous drooling of saliva, coughing and cyanosis during feeding, ऐसे बेबी के लिए the first step that you are going to do, it is going to put a infant feeding tube. I'm going to put an infant feeding tube, or also called as the Ryle's tube, or also called as the nasogastric tube, ठीक है। तीनों के एक ही नाम है। तो आप पहले इन्फेंट फीडिंग ट्यूब डालोगे। आप बोलोगे सर फीडिंग ट्यूब क्यों डालना है, फीड थोड़ा ना करना है। सही बात है, फीड थोड़ा ना करना है। क्या करना है, यू हैव टू मेक श्योर ऑल दैट सलाइवा दैट इज गेटिंग पूल्ड इन, नो यू हैव टू सक इट आउट, ठीक है। आप उसके अंदर को छोड़ना नहीं चाह रहे, क्यों, यही एस्पिरेशन का कॉज है। आगे चल के बेबी ना इसकी वजह से नहीं मरेगा, ही ड्राई बिकॉज ऑफ एस्पिरेशन न्यूमोनाइटिस, ठीक है, लंग कॉम्प्लिकेशंस। आई डोंट वांट दैट टू हैपन। तो द मिनट आई एम थिंकिंग देयर इज सम प्रॉब्लम, तो पहले तो मैं ये ट्यूब डालूंगा एंड आई कनेक्टेड। सो इन्फेंट फीडिंग ट्यूब इज पुट एंड connected to a negative suction, connected to negative suction। अच्छा, अब जैसे ही आपने इसको नेगेटिव सक्शन का कनेक्ट किया, यू विल सी दैट ऑल दैट सलाइवा विल बी कंटिन्यूअसली सक्ड आउट ऑफ इट। नाउ माय बेबी इज सेफ। मेरा बेबी नहीं है, जिसका भी बेबी है वो सेफ है। क्यों सेफ है, बिकॉज देयर इज नो फर्दर रिस्क फॉर एस्पिरेशन। इसका मतलब ये तो नहीं कि डायग्नोसिस बना लिया, तो डायग्नोसिस बनाने के लिए क्या करोगे नाउ, क्योंकि अभी ट्यूब तो डाली दी है, तो इन्वेस्टिगेशन के लिए ले जाते हैं। तो पहला इन्वेस्टिगेशन क्या करोगे, देखो अभी ट्यूब अंदर है, सो यू वांट टू गेट एन एक्सरे डन, ठीक है। तो कॉफिंग है, साइनोसिस हो रहा है, रीजर्टेशन हो रहा है, तो एक बार एक्सरे करा के देख ही लेते हैं, ठीक है। द फर्स्ट थिंग वो रेडली अवेलेबल है, तो फर्स्ट थिंग इट इज गोइंग टू बी एक्सरे ऑफ द बेबी। तो एक्सरे में आप देखोगे जो राइल्स ट्यूब आपने डाला था ना, वो राइल्स ट्यूब यहाँ जाएगा एंड देन आगे जाने का जगह नहीं है, तो राइल्स ट्यूब ऐसे कॉइल हो जाएगा, राइट। जैसे अब राइल्स ट्यूब होगा, राइल्स ट्यूब अंदर जाएगा और ये गोल 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 अंदर घूम जाएगा। एक्सरे में राइल्स ट्यूब दिखती है, राइल्स ट्यूब इज बेसिकली हैविंग अ लाइन। अगर आपने राइल्स ट्यूब देखा होगा ना, एक ऑरेंज कलर की लाइन या ग्रीन कलर की लाइन देखने को मिलेगी। वो लाइन क्या, वो रेडियो ओपेक लाइन है जो आपको रेडियोग्राफ में दिखेगी। देन यू विल सी ऑन एन एक्सरे देयर विल बी प्रेजेंस ऑफ कॉइलिंग ऑफ, देयर इज कॉइलिंग ऑफ नेसोगैस्ट्रिक ट्यूब। जैसी कॉइलिंग, अब मुझे पता है कि देखो ईसोफेगस में अट्रीसिया है, ठीक है, गली गली में शोर है ईसोफेगस में अट्रीसिया है। कैसे पता चला, बाय लुकिंग एट दिस कॉइलिंग ऑफ द नेसोगैस्ट्रिक ट्यूब। जैसी कॉइलिंग का मुझे कंफर्म करना है, कैसे कंफर्म करोगे, आई एम गोइंग टू यूज अ कॉन्ट्रास्ट इमेजिंग। अब ये कॉन्ट्रास्ट इमेजिंग क्या होता है, देखो कॉन्ट्रास्ट इमेजिंग के लिए ना आप बोलोगे कि इस बेबी को रेडियोलॉजिस्ट के पास भेज दोगे, रेडियोलॉजिस्ट एक छोटा सा सिरिंज लेगा 10 cc का, उसमें कॉन्ट्रास्ट डालेगा, थोड़ा सा डाइल्यूट करेगा और कॉन्ट्रास्ट बेबी के मुंह में डाल देगा और एक्सरे ले लेगा। और जैसे ही लेगा देखोगे कॉन्ट्रास्ट आगे जा ही नहीं रहा, वो तो पुल अप हो गया, एंड दैट पुलिंग ऑफ द कॉन्ट्रास्ट इज गोइंग टू गिव यू अ डायग्नोसिस, एंड दिस कॉन्ट्रास्ट इमेजिंग इज डन। तो अगर कौन सा सेफेस्ट कॉन्ट्रास्ट टू पुट इन अ बेबी, द सेफेस्ट कॉन्ट्रास्ट to put in the baby is going to be iohexol, ठीक है। iohexol जो है ये वाटर soluble कॉन्ट्रास्ट है। अब जैसे ही मैंने iohexol कॉन्ट्रास्ट डाला, अब तो कंफर्म ही हो गया, ठीक है ना। कॉन्ट्रास्ट डालने में क्या होगा कि ये जो जैसे ही आप कॉन्ट्रास्ट डालोगे ना, what is going to happen, the minute you put in the contrast in the oral cavity, you will notice कि वो कॉन्ट्रास्ट जाके यहाँ पे अटक जाएगा, and this filling of the contrast and unable for the contrast to move any further, ठीक है। दैट पूलिंग ऑफ द कॉन्ट्रास्ट एक जगह पे रुक गया, इसका डायग्नोसिस हो गया कि इसोफेजियल एट्रीसिया है। तो हम बोलते हैं, एज अ नोट पॉइंट याद रखना, हर उस बच्चे को जिसको एट्रीसिया उसको फिस्टुला भी होगा। दैट इज एवरी चाइल्ड हु इज नोन टू हैव एन इसोफेजियल एट्रीसिया इज कंसीडर्ड टू हैव अ ट्रेकियोएसोफेजियल फिस्टुला अंटिल अनलेस प्रूवन अदरवाइज, ठीक है। तो ये मान के ही चलना है कि बेटा कि इस बच्चे को फिस्टुला है ही, ठीक है। नाउ एक तो मैंने डायग्नोस कर लिया, ठीक है, बधाई डायग्नोसिस मिल गया। अब बारी आती है कि मैनेजमेंट की, क्या मैनेज करोगे। लेकिन मैनेज करने से पहले ना, एवरी बेबी हु हैज अ ट्रेकियोएसोफेजियल फिस्टुला मस्ट बी इवैल्यूएटेड बिकॉज दे आर नोन टू हैव अदर कॉन्जेनाइटल कंडीशंस। सो अदर कॉन्जेनाइटल डिसऑर्डर्स, other congenital disorders, other congenital disorders associated with tracheoesophageal fistula, right? So what are the other congenital disorders? What are the other congenital disorders associated with tracheoesophageal fistula? तो इसके लिए ना हमारे पास एक निमोनिक है. निमोनिक का नाम क्या है? इसको हम बोलते हैं वैक्ट्रल. सो वैक्ट्रल से याद रख लेना, जब भी कोई बेबी टॉफ का आएगा ट्रेकियोएसोफेजियल फिस्टुला का, आपको ये चीजें इवैल्यूएट करनी है. तो इस इवैल्यूएशन में क्या क्या है? V stands for vertebral body defect. It is going to be the vertebral body defect. A stands for anal atresia. The anal opening is missing. C stands for cardiovascular abnormality. अब जब भी CVS, that is cardiovascular abnormality बोलोगे, it can be your that is okay. We have PDA, that is patent ductus arteriosus, or it can have ventricular septal defect. ठीक है, usually PDA और VSD होता है. PDA stands for patent ductus arteriosus, VSD stands for ventricular septal defect. ठीक है, and then you have TE. तो इतना है, T से याद रखना tracheoesophageal fistula, and E stands for esophageal atresia. So as I told you, every patient who has a tracheoesophageal atresia will be associated with tracheoesophageal fistula as well. R stands for your renal vectral है ना, L कहाँ चला गया? L भूल गए? ठीक है. R stands for renal abnormalities. In renal abnormality में this baby can be associated with horseshoe kidney और also associated with renal agenesis, कि किडनी बनी ही नहीं है. ठीक है. L stands for limb abnormality. Limb abnormality में most commonly बेबी का हाथ छोटा मिलेगा, that is a radial hypoplasia. That is going to be the radial hypoplasia. ठीक है. So this is how the various disorders are to be evaluated. अच्छा, इन्वेस्टिगेशन में एक और याद रख लेना, H टाइप वैरायटी में ना, क्योंकि H टाइप में जब आप डालोगे, you will see the contrast will go into the stomach, some amount of contrast will also go into the trachea also. तो H टाइप में कभी कभार ना there is a possibility you can mix or you can miss out. तो यहाँ पे in H टाइप वैरायटी bronchoscopy with contrast, that is GI contrast imaging. So बेबी को सेडेट करेंगे, ब्रोंकोस्कोप डालेंगे, मुंह में कॉन्ट्रास्ट डालेंगे, एंड देन विल वेट. तो स्कोप में देखेंगे कि कहीं से निकल रहा है कि नहीं निकल रहा है. इफ इट कम्स इनटू द ट्रेकिया, इट इज अ कॉन्फर्मेटरी फॉर H टाइप वैरायटी. ठीक है, तो ये आपका ट्रेकियोएसोफेजियल फिस्टुला के क्लिनिकल फीचर्स हो गए, इन्वेस्टिगेशन हो गया, अदर एसोसिएटेड कॉन्जेनाइटल डिसऑर्डर्स हो गया. अब बारी आती है मैनेजमेंट की, कैसे मैनेज करोगे. सो मैनेजमेंट ऑफ द ट्रेकियोएसोफेजियल फिस्टुला हैज टू बी सर्जरी. ठीक है, तो जब भी आप सर्जरी के लिए बोलोगे, नंबर 1 कि सर्जरी इस बेबी के लिए कौन से पोजीशन में करोगे. द पोजीशन दैट हैज टू बी गिवन फॉर दिस बेबी. देखो, ईसोफेगस को एक्सेस करने के लिए बेस्ट राइट साइड होता है, क्योंकि लेफ्ट साइड में आपका आयोटा आएगा. ठीक है, तो राइट से आना ज्यादा बेटर है. तो पेशेंट को आप लेफ्ट साइड में टिल्ट करके रखोगे. तो पोजीशन ऑफ दिस बेबी इज गोइंग टू बी लेफ्ट लैटरल डिक्यूबिटस. ठीक है, अब कौन सा इंसिशन दोगे? द इंसिशन दैट इज गोइंग टू बी पुट इज गोइंग टू बी राइट पोस्टेरोलैटरल थोरोकोटमी. ठीक है, तो इस बेबी को आप लैटरली लेटाओगे. सो दिस इज अ बेबी, लेट्स से द बेबी इज गोइंग टू बी पुट on the lateral side and the baby is going to put on the left lateral side, exposing the right side. So this is the baby. तो ये बेबी को हमने ऐसे रखा हुआ है. ठीक है, so this is how the baby is put on the lateral side. तो बेबी को ऐसे साइड में लेटाया हुआ है. ठीक है, अब आप बोलोगे पोस्टेरोलैटरल थोरकोटमी कौन सी है. मान लीजिए कि ये डायाफ्राम है बेबी का, ये मिड एक्सिलरी लाइन है, जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग. posterior thoracotomy में the incision would be like this, ठीक है. So the incision would start like this. This is the incision. This is on the lateral side. तो यहाँ से यहाँ तक इस incision को बोलते हैं posterior lateral thoracotomy, ठीक है. तो position हो गया left lateral, incision हो गया right posterior lateral thoracotomy. So in the surgery, it is going to be resection, or I say we're going to do a ligation of tracheoesophageal fistula with primary anastomosis, of esophagus over nasogastric tube. इसका मतलब क्या है? मतलब बड़ा सिंपल सा है. आई एम सेइंग कि अभी जो हमारे पास पेशेंट आया है, ये आपका ट्रेकिया है, यहाँ पे फिस्टुला बना हुआ है, so this is the trachea that is present. This is the tracheal esophagus. This is where the fistula is formed, and this is where the stomach is present. ठीक है. So what we are saying is we have to ligate the tracheoesophageal fistula and do a primary anastomosis. इसका concept बहुत simple है. I'm going to put a ligature here. That means I'm going to put a tie here. ठीक है. Tie डालने के बाद I'm going to excise this end. Once I'm done tying, I'm going to excise this end. Now I have the esophagus which has been excised from this side. ठीक है. तो अभी we have the esophagus which is here. ठीक है. Excise करके यहाँ रखा हुआ. Right. Now what I'm going to do is I'm going to take a nasogastric tube, pass into the upper esophagus, और इस esophagus के upper end पे will create a small opening. ठीक है. Equal, मतलब opening जो है it should be equal to the same size of the lumen here. Now once you open the lumen, I will pass the nasogastric tube and then I will put the nasogastric tube into the stomach. Once you have done this, now I am going to create an anastomosis here. Right. So once you have done this, I'm going to create the anastomosis here, and this is where you will notice. Once the anastomosis between these two ends is done, I will leave it here. So that is what it is. Ligation of the tracheoesophageal fistula with primary anastomosis of the esophagus over the nasogastric tube. Why over the nasogastric tube? Because I want this baby to be fed post-operatively. अगर ट्यूब नहीं होगा तो कैसे फीड करोगे? क्योंकि एनास्टोमोटिक साइट तो ऑलरेडी एडिमेटस होगा. अभी तो इंजरी हुई है ना. In your wound repair or your see, anywhere there is an injury, there will be an inflammation. Repairing an anastomosis done with sutures, needles and all, obviously there will be injury, there will be edema. तो बेबी को immediate post-operative में डायरेक्ट फीड नहीं कर सकता. तो I'll be feeding with nasogastric tube. Right. So this is how you're going to manage your kids or your babies with tracheoesophageal fistula and atresia. Now, one thing, if you want to impress your examiner, if there is an inadequate length, right? If there is a long distance atresia. Now, what do you mean by a long distance atresia is? If there is a long distance atresia. अब ये long distance atresia का मतलब क्या होता है? In a long distance atresia, you will say the upper esophageal segment and the lower esophageal segment after excising the fistula has a distance which is going to be more than 2 vertebral body distance. So this distance, if it is measured, if it is more than 2 vertebral body defect, if it is more than 2 vertebral body, if it is more than 2 vertebral body distance, it's a long distance atresia. Here I cannot pull and make an anastomosis, it will be under a lot of tension. So in this, what should be done? I will do a feeding jejunostomy. And after doing the feeding jejunostomy, after 6 months, if there is an adequate length, I can go with primary anastomosis. Or I can answer primary, I'll go with anastomosis. I will go ahead with anastomosis, or I will go with interposition surgery. Now, ये interposition surgery क्या होता है? Interposition surgery, because you do not have adequate length, I can take some end of the bowel. कोई दूसरा bowel का loop लेके आके I can keep in between them and then make the continuity. ये जो नया segment आपने डाला हुआ ना, जो नया आपने replacement किया हुआ है, इसको आप बोलते हो that is your interposition surgery. Now for the interposition surgery, what all can I use? Number one, I can use stomach. Number two, I can use jejunum. And number three, I can use colon. जब भी colon होगा, left will be preferred over right. Left will be preferred over right. So stomach, jejunum, and colon. So there will be all these are preferred. We are doing an interposition surgery. Okay? So this is how you are supposed to, answer your questions on tracheoesophageal fistula and atresia. Clear है यहाँ तक? ठीक है? Sorted? Quick feedback. तो हमारा पहला सवाल खत्म हुआ, right? So the first question was tracheoesophageal fistula, and we have discussed each and every single point that has to be written in your exam paper. सही है? Yeah. Can you move on? So the next topic, that is going to be about GERD. So the second next question that you have is going to be about GERD. GERD stands for gastroesophageal reflux disease. That is a gastroesophageal reflux disease. Please inform the team to upload your handwritten notes in the app like other faculty. They're not doing it, huh? Okay. Med student, I have taken the note from it. I'll just after the class we'll try to give them the same context. ठीक है? अगर नहीं हुआ होगा तो आज तीनों लेक्चर्स के करा देंगे जो हमने फ्राइडे लिया था, सैटरडे लिया था, आज संडे ले रहे हैं. ठीक है? So GERD stands for gastroesophageal reflux disease. Now, जैसे मैंने आपको बताया था, the first thing will always be the definition. Now, the definition of GERD is, it is defined as pathological reflux. If it is a pathological reflux of gastric content, into the esophagus, due to decreased or loss of tone of lower esophageal sphincter. Right? So it's a pathological reflux of the gastric content into the esophagus due to decrease or loss of tone of the lower esophageal sphincter is what we call it as GERD. Okay? Now, when you talk about what happens and what is the reason why there's a decrease in the tone of lower esophageal your tone or the lower esophageal sphincter. So when you talk about the causes in general. So when you talk about the cause, so I'm going to divide the cause into two important components. In the cause, one that decreases, one that reduces, or the risk factor for decreasing the lower esophageal sphincter tone, and then risk factor directly for GERD. Right? So all these factors, see, ultimately when there's decrease in the tone of lower esophageal sphincter, the patient will develop a GERD, but we'll try to divide it into two subsets. One is one that decreases the tone of LES and one that is going to cause GERD. Okay? So how do you remember it? Now the one that decreases the tone of LES, the most important risk factor is going to be smoking. ठीक है? तो कभी भी आपने ऑब्जर्व किया होगा कि अगर कोई स्मोक कर रहा है ना, तो एक हाथ में सिगरेट है और दूसरे हाथ में ऑब्वियसली चाय या कॉफ़ी है. ठीक है? तो अकेला स्मोकिंग नहीं करेगा ना, चाय सुट्टा तो लगता ही है. ठीक है? सुट्टे के साथ चाय, अगर इंडिया में हो, बाहर जाओगे तो कॉफ़ी होगा, तो कॉफ़ी में क्या मिलेगा आपको? कैफीन मिलेगा. ठीक है? अब जैसे कैफीन इज ऑल्सो गोइंग टू डिक्रीज द टोन ऑफ एलियस. अब देखो, यू हैव हैड कॉफी, ठीक है, सुट्टा भी मार लिया, अब घर वापस जाना है, मम्मी को पता नहीं चलना चाहिए, ठीक है, मम्मी से छुपाओगे कैसे? तो यू विल ईट समथिंग टू हाइड दैट स्मेल. यूजुअली कुछ मीठा खा लोगे ताकि अच्छा भी लगे, तो दैट इज गोइंग टू बी चॉकलेट्स. सो द चॉकलेट्स विच आर गोइंग टू डिक्रीज द टोन ऑफ एलियस फर्दर. अब पूरा दिन पढ़ाई, लाइफ, मेडिकल कॉलेज, एग्जाम, तो यार इंसान इतना भी मतलब इतना मारोगे तो टूटेगा ही ना. तो एक ही चीज़ जोड़ के रखेगी, क्या है, ठीक है. तो स्मोक भी कर लिया, कैफीन भी होगी, चॉकलेट भी हो गया, पूरा दिन थके हारे हो तो रात को रिलैक्स करना है. एंड द बेस्ट वे टू रिलैक्स इज व्हाट? द बेस्ट वे टू रिलैक्स, आई एम नॉट प्रमोटिंग इट, बट दी यूजुअली व्हाट पेशेंट्स डू इज गोइंग टू बी अल्कोहल. तो स्मोकिंग हो गया, कैफीन हो गया, चॉकलेट हो गया, अल्कोहल हो गया. दारू पी ली तो कल सुबह क्या होगा? हैंगओवर होगा, हैंगओवर होगा तो सर दर्द होगा. अब सर दर्द से बचने के लिए क्या करोगे? यू स्टार्ट टेकिंग सर्टेन ड्रग्स, medications. Drugs that decrease the tone of LES can be remembered as A, B, C, D. A stands for anticholinergic. B stands for barbiturates. C stands for calcium channel blocker. D stands for diazepam. Right? So anticholinergic, barbiturates, calcium channel blocker and diazepam is the one that decreases the tone of LES. ठीक है. इसके साथ साथ अगर आप प्योरली रिस्क फैक्टर बोलोगे जीआरडी की, दी प्योर रिस्क फैक्टर्स ऑफ जीआरडी इज गोइंग टू बी ओबेसिटी. ओबेस पीपल में लोअर स्फिंक्टर का टोन अपने आप खराब हो जाता है. देन इज प्रेगनेंसी. प्रेगनेंसी में ऐसा क्या जादू होता है कि पेशेंट को जीआरडी होने लगता है? प्रेगनेंसी इज गोइंग टू बी अ प्रोजेस्टेरॉन ड्रिवन स्टेटस एंड प्रोजेस्टेरॉन का कॉन्सेंट्रेशन ज्यादा होगा. व्हाट इज द इफेक्ट ऑफ प्रोजेस्टेरॉन ऑन द स्मूथ मसल? इट कॉजेस स्मूथ मसल रिलैक्सेशन. लोअर ईसोफेजियल स्फिंक्टर जो है वो स्मूथ मसल है, सो अंडर द इन्फ्लुएंस ऑफ your progesterone it relaxes, तो GRD होगा. Same reason है उनको, they have incontinence in the bladder. The same reason they have easy passage of flatus and stools. All that happens because of progesterone. ठीक है. तो obesity हो गया, pregnancy हो गया, systemic एक connective tissue disorder ना, that is going to be scleroderma. So there is obesity, there is pregnancy, and there is associated with scleroderma. All these are going to be an attributed risk factors. तो अभी तो मैंने बताया drugs, these are the one that decrease the tone of lower esophageal sphincter. ठीक है, इतना मिनिमम आपको याद रखना है. क्लियर है? ठीक है, सॉर्टेड है, राइट. Now these are the causes of GRD per se. Now how would a patient of GRD is going to present to you? So we'll talk about the clinical features. We're going to talk about the clinical features of GRD. So when you look at the clinical features of GRD, उसको समझने के लिए let's understand the basic objective. ये आपका esophagus है, ये आपका stomach है, ठीक है, clear है. This is going to be your diaphragm, ठीक है. फिर आप देखोगे ये जो lower part है, this is what is your lower esophageal sphincter, ठीक है. Now lower esophageal sphincter is basically an anatomy, it's a physiological sphincter. ठीक है, तो esophagus में दो sphincters हैं, सबको पता है, upper esophageal sphincter, lower esophageal sphincter. Upper esophageal sphincter is going to be your anatomical sphincter, lower esophageal sphincter is going to be your physiological sphincter. फर्क क्या है? anatomical sphincter में एक्चुअली एक स्ट्रक्चर है जो स्फिंक्टर की तरह बिहेव करता है. फिजियोलॉजिकल में कुछ नहीं है, ल्यूमन खाली है, लेकिन सब उसको दबा के रख रहे हैं. एंड बिकॉज ये दबा हुआ है, इसको खोलने के लिए कुछ प्रेशर लगेगा. अगर जब तक प्रेशर नहीं दोगे खुलेगा नहीं. एंड दैट कोलैप्स सेगमेंट व्हिच रिक्वायर्स सर्टेन अमाउंट ऑफ प्रेशर टू ओपन is going to behave as sphincter. तो ये एरिया स्फिंक्टर की तरह बिहेव करता है. क्या क्या रीजंस हैं? एक तो आपका डायाफ्राम, ये देखो डायाफ्राम जाएगा, इसको जकड़ के रखेगा. इट इज द डायाफ्रामेटिक मसल, वी कॉल इट एज द क्रस ऑफ द डायाफ्राम, द क्रस ऑफ द डायाफ्राम व्हिच इज गोइंग टू, इट इज द डायाफ्रामेटिक क्रस व्हिच इज गोइंग टू होल्ड द इसोफेगस. तो इसोफेगस को ये जो डायाफ्रामेटिक क्रस है दबा के रखता है, ठीक है. तो एक तो ये हो गया, डायाफ्रामेटिक मसल्स हो गया. दूसरा क्या हो गया? सेकेंड थिंग दैट यू विल नोटिस, the second thing that you will notice is going to be the intra-abdominal length of the esophagus. देखो normally जो esophagus है ना 25 सेंटीमीटर का होता है. The entire esophagus your 25 centimeters. This is what we call it as the intra-abdominal esophagus. अब जो intra-abdominal esophagus है that is going to be approximately 4 to 5 centimeters. Now इससे objective क्या? The objective here is in the thorax there is negative pressure, and we all know negative pressure का मतलब होता है pulling pressure, और abdomen में क्या है, positive pressure. तो यहाँ पे esophagus खिंच रहा है और positive pressure से esophagus दब रहा है, तो obviously this part of the esophagus is going to get compressed, and that compression is going to result in sphincter like mechanism. तो एक तो आपका हो गया crust of the diaphragm, दूसरा intra-abdominal length of the esophagus, तीसरा क्या होगा, you will notice that this particular angle where you can see the esophagus is going in and then the stomach is taking out, ठीक है, ये जो esophagus और stomach के बीच का angle है, esophagus और stomach के बीच का angle है, इसको बोलते हैं angle of His. ये बहुत acute है, तो it is going to compress the esophagus. फिर आप देखोगे there are these muscle fibers which are present, which are going to be a sling muscle fibers. ये fundus के muscle fibers हैं जो lower part of the esophagus के साथ encircle कर रहे हैं, ठीक है. So all the sling muscle fibers, no, they're arching around the lower part of the esophagus. तो जब ये contract करेगा ना तो इसको दबाएगा. So it's like a sling-like action, like a rubber band action. तो इसको दबा के रखेगा. That is going to behave its sphincter. तो एक तो crust of the diaphragm हो गया, intra-abdominal length of the esophagus हो गया, angle of His हो गया, your fundus, that is going to be your muscles which are going to sling muscle fibers. Then you have hypertrophied circular muscles in this area, increased tone in the lower part of the esophagus. All these are going to predict or attribute to that of the lower esophageal sphincter. हमारा ऑब्जेक्टिव है स्फिंक्टर समझने का नहीं है, हमारा ऑब्जेक्टिव है कि ये देखने के लिए कि जीआरडी में हो क्या रहा है. अब जीआरडी में ये पूरे स्फिंक्टर मैकेनिज्म की ना वाट लग जाती है. हियर द एंटायर स्फिंक्टर मैकेनिज्म इज लॉस्ट, or I can say it has become weakened. Now what is going to happen if the sphincter mechanism is going to be weakened? There is nobody who is going to stop the content from going from the stomach into the esophagus. तो क्या होगा अगर चला भी गया तो, ठीक है. So you need to understand that the entire esophagus is lined by the squamous epithelial cell. The entire esophagus is lined by the squamous epithelial cell. The last 2 centimeters of the esophagus, is lined by columnar epithelial cell. और यहाँ से आप देखोगे that it is the entire GIT all the way to the dentate line of the anal canal. It is going to be lined by your columnar epithelial cells. Problem columnar epithelial cell का नहीं है. I mean, in fact, the columnar epithelial cells is what it protects the stomach from getting burnt from the acid that is going to be released. That is your hydrochloric acid. Stomach में hydrochloric acid release होता है. इसी के stomach का pH is going to be 2 to 1.5 to 2. है ना? Now, what is going to happen is this, whichever columnar cells which are present, they are going to have mucus producing cells, and that mucus producing cells is going to produce mucus, and that mucus secretion is going to act as a thick membrane like barrier. ठीक है, तो इन cells के ऊपर ना, these are mucus producing cells are there. These mucus producing cells produces mucus. Now this mucus is going to act as a mechanical barrier, और इसके साथ साथ एक और बहुत important property है इस mucus की. This mucus is rich in bicarbonate. ठीक है, अब क्या होगा, you will see that in the stomach we have the specialized cells, and these specialized cells are what we call it as parietal cells. These parietal cells are going to secrete hydrochloric acid. अब ये जो hydrochloric acid है वो आके stomach के surface पे गिरेगा. Now when the hydrochloric acid falls onto the surface of the stomach, एक तो barrier है तो underlying cells damage नहीं होते, दूसरा क्या है, bicarbonate is a base, no, acid और base neutralize हो जाएगा. ठीक है, तो it won't allow the acid to penetrate deeper. And that's why, you know, stomach के अंदर even though there is secretion of acid, it does not cause any damage to the any epithelial surface because of this mechanism which is present. लेकिन जैसी tone कम होगा, what will happen, you will see now the acid will start to reflux. ठीक है, initially वो last 2 centimeters of the esophagus पे गिरेगा जहाँ पे already columnar epithelium है, वहाँ पे कोई problem नहीं होगी. लेकिन as the reflux becomes progressive, this is now going to go and fall onto the squamous epithelial cell. ठीक है, तो आप देखोगे ये पूरा जो है हमारा esophagus is lined by the squamous epithelial cells. ठीक है, अब ये जो squamous epithelial cells है, इनके पास तो mucus producing cells है नहीं, they cannot produce mucus. If they cannot produce mucus, इनको बचाएगा कौन, इनको कोई नहीं बचाएगा. जब acid आके इस पे गिरेगा, what is going to happen, the minute the acid is going to come and fall on it, you will see that these cells will be burnt. तो ये जल जाएंगे. ठीक है, यहाँ से धुआं निकल रहा है. ठीक है, just for this artistic satisfaction, आप देखोगे कि यहाँ पे जल के इन सेल्स में से धुआं निकल रहा है. अब यही बर्निंग सेंसेशन आपका पेशेंट भाग के दौड़ के आएगा, डॉक्टर साहब जल रहा है. क्या जल रहा है? So the first complaint that the patient is going to present to you is going to be a retrosternal heartburn. It is going to be your retrosternal heartburn. अब ये जो रेट्रोस्टर्नल हार्टबर्न है, इट इज व्हाट दे डिस्क्राइब्ड एज दिल जले, सच में दिल जल, इसका सच में जल रहा है यार, वो तो अलग कॉन्टेक्स्ट में बोल रहे हो कि दिल जल रहा है, इसका तो सच में जल रहा है, बर्न हो रहा है इसलिए तो आ रहा बेचारा. सो इज रेट्रोस्टर्नल हार्टबर्न इज प्रेजेंट. नाउ अलॉन्ग विथ एंड ये जो रेट्रोस्टर्नल हार्टबर्न है, इट विल बी सडन एंड सिवियर इन ऑनसेट. दिस इज गोइंग टू बी सडन एंड सिवियर इन ऑनसेट. कभी कभार तो ऐसे भी लगता है ना पेशेंट को एंजाइना लाइक अटैक आ गया, इतना दर्द होता है. ठीक है. सो रेट्रोस्टर्नल हार्टबर्न, इट इज बिकॉज इट इज गोइंग टू हैव अ सडन सिवियर ऑनसेट, दैट इज बिकॉज ऑफ बर्निंग ऑफ द स्क्वामस एपिथेलियल सेल. नाउ बिकॉज द टोन इज बिकमिंग लेस, अब टोन अगर छूटने लगा, टोन कम हो गया, तो ऑब्वियसली द कंटेंट ऑफ द स्टमक विल कम इनटू द esophagus from there into the mouth and then out. So will be regurgitation. There will be regurgitation of food particles. There will be regurgitation of food particles. Now because there is a damage in the esophagus, and that damage in the esophagus is nothing but damage in the foregut. जितना भी आपका foregut derivatives है, उसका जो referred pain होगा वो epigastric region में होगा. midgut is going to be periumbilical region, hindgut is going to be in the pelvic region. तो यहाँ पे दर्द कहाँ पे होगा, जल यहाँ पे रहा है, दर्द सेंटर में होगा. there will be presence of epigastric pain as well. There will be presence of epigastric pain. So a sudden severe onset of retrosternal heartburn, there will be regurgitation of food particles, they are going to have an epigastric pain. A patient continues to ignore, what is going to happen? The next stop is going to be, as the reflux becomes more and more progressive, अब ये आके patient के जीभ पे गिरेगी. So now you will see this acid as it continues to reflux. One fine day it will fall onto the tongue, and once it falls onto the tongue, right, patient will be able to taste the acid. और जैसे ही acid को taste करेगा, अच्छा थोड़ा ना लगता है यार, एसिड का टेस्ट खट्टा खट्टा सा होता है, तो इसी को वो बोलता है कि सर कुछ खट्टा लग रहा है, एंड दैट इज गोइंग टू बी अ सार ब्रश. ठीक है. सो दिस इज गोइंग टू बी एसोसिएटेड विद सावर ब्रश. सो रेट्रोस्टर्नल पेन, regurgitation of food particles, epigastric pain, sour brush is there. इसके साथ साथ व्हाट एल्स कैन यू सी. ठीक है. तो ये सब तो जीआई फीचर्स हो गए. रेट्रोस्टर्नल हार्टबर्न, regurgitation of food particles, epigastric pain, sour brush is what you see the GI features. इसके साथ साथ ना, टू इम्प्रेस योर एग्जामिनर्स, यू कैन ऑल्सो राइट द एक्स्ट्रा GI मैनिफेस्टेशंस. This is going to be an extra GI manifestation. Now all that acid that is going to reflux, right? Now that reflux is going into the mouth, that is into the tongue, no? In between you have pharynx also, right? So it is going to be associated with laryngitis. It is going to be associated with pharyngitis. This will also be associated, क्योंकि जैसे acid is going to go into aspiration, when it is going up, no, it can revert back into the trachea also, right, as an aspiration. When it goes, it is going to cause tracheal irritation, and that will cause damage in the trachea, and that damage in the trachea and then into then the content goes into your smaller your airways, that is your alveoli and all, that is going to result like asthma like features. Now, damage of the lungs will also be associated with pulmonary fibrosis. So this is associated with laryngitis, is associated with pharyngitis, asthma, pulmonary fibrosis. And because another very interesting thing, no, as the acid reflux into the mouth, it is going to hit the teeth. Now on the teeth, on the surface of the teeth, you have a protective cover called as enamel. This whitish layer that is called as enamel. Enamel was acid sensitive. Enamel is extremely acid sensitive. The minute acid comes and falls onto the enamel, it will disrupt the enamel. Disruption of the enamel will result in yellowing of teeth. This will result in yellowing of the teeth. So there is laryngitis, pharyngitis, asthma, pulmonary fibrosis, and yellowing of the teeth are the extra GI manifestations of the GERD. Okay, so GERD mein both your GI and extra GI manifestations you have spoken about. Okay, now what are the complications which are associated with GERD? Complications associated with GERD. Complications associated with GERD. Okay. So what are the complications that are associated with GERD? Now the first thing, as the esophagus is getting repeatedly abused and damaged, so there will be inflammation, and that will result in esophagitis. This will result in esophagitis, right? Now, this esophagitis, which is going to be occurring secondary to GERD, there's a very important finding that you have radiographically. That is what we call it as the feline esophagus. Now, feline esophagus is nothing but an esophagus with stacked mucosal ring-like appearance. So, feline esophagus, it will have stacked mucosal ring appearance. Other conditions where you will see feline esophagus is also seen in eosinophilic esophagitis. Also seen in eosinophilic esophagitis. It is also seen in eosinophilic esophagitis. Okay? So this is one of the common complications. Now, as the acid refluxes, it causes injury to the esophageal mucosa. That injury to the esophageal mucosa will heal by inflammation. That is called as esophagitis, right? Now, repeated inflammation anywhere in the body is going to heal by fibrosis. The GERD is not treated. This esophagitis will occur repeatedly. Repeated esophageal inflammation. Repeated inflammation healed by fibrosis, and that fibrosis will result in esophageal stricture. This is going to result in esophageal stricture. Now, whenever there is a stricture, stricture is because of fibrosis. In fibrosis, tissue condenses. Condensation of the tissue, the esophagus is this lengthy, because there is an inflammation, this fibrosis, the esophagus is going to condense. This condensation of the esophagus will result in shortening. This is going to result in shortening in the length of the esophagus. This will result in shortening in the length of the esophagus. So there is esophagitis, there is esophageal stricture, shortening in the length of the esophagus. Now, whenever the esophageal length gets shortened, now there is something very interesting that you need to understand, that if this is the esophagus, this is the stomach that you have. We have just discussed that some amount of the esophagus is going to be below the level of diaphragm. This is called as the intra-abdominal esophagus, and this is your gastroesophageal junction. Now, if there is a stricture which is present in the esophagus, if there is a stricture that is going to be present in the esophagus, this stricture is going to heal by fibrosis. Now, because of fibrosis, you will see this tissue is going to condense. Now, as the tissue condenses, you will notice that that is your gastroesophageal junction, which is present here, will now migrate. And if they migrate above the level of diaphragm, this migration of the gastroesophageal junction from intra-abdominal space into intrathoracic space over the diaphragm is what we call it as sliding hiatal hernia. This is what we call it as the sliding hiatal hernia. This is what we call it as the sliding hiatal hernia, right? So, esophagitis, esophageal stricture, esophageal stricture. Just give me 1 second, guys. Okay, sorry. Yeah. So I was saying esophagitis, esophageal stricture, shortening in the length of the esophagus, sliding hiatal hernia. Along with that, there's a condition which is called as the Barrett's esophagus. It is called as the Barrett's esophagus. So Barrett's esophagus is a short note exam question also. So what is this Barrett's esophagus? Right. So first, what is the cause for the Barrett's esophagus? The cause, it is because of long standing. It occurs due to long standing untreated GERD. The long standing untreated GERD. What is the pathophysiology behind it? The pathophysiology behind the Barrett's esophagus. The pathophysiology behind the Barrett's esophagus is, normally you see that the squamous epithelial cells are going to be sensitive So if you take this as the representation of the esophagus, right? You take this as a representation of the esophagus. We have the squamous epithelial cells which are present here, and then you had a columnar epithelial cells which are present. We all know that the columnar epithelial cells are protective from acid because of their ability to secrete mucus. Because of their ability to secrete mucus. So what is going to happen, that every time the acid is going to come and fall, here there is no impact for the acid. But when the acid comes and falls onto the squamous epithelial cells, it is actually causing the damage in this area. So body says there is a repeated damage in the squamous epithelial cells. How do I overcome it? तो अभी तो बाजू में देख रहे हैं ना, he's drawing the inspiration. कॉलमनार है तो कोई दिक्कत हो ही नहीं रही है, स्क्वामस हो रहा है तो बैंड बज रहा है, तो बॉडी बोलते काम करते हैं, स्क्वामस को कॉलमनार में बदल देते हैं. And now this is where the body says I am going to transform myself, and this transformation is the squamous epithelial cells are now going to get converted. The squamous epithelial cells are now going to get converted into your columnar epithelial cells. But as they do so, they take additionally one more thing. Now what is that one more thing additionally? They secrete or they present to you with the goblet cells. So they start producing some specialized cells which are called as goblet cells. Now goblet cells क्या करते हैं? They produce mucin. ठीक है? Now what has happened is, in order to survive this entire battle, we have noticed that these squamous epithelial cells, these squamous cells have now transformed into columnar epithelial cells. But along with columnar epithelial cells, they also have presence of goblet cells. Now goblet cells usually body में कहाँ मिलेंगे? वो intestine में मिलेंगे. ठीक है? Now you see squamous is converting into columnar. It is called as metaplasia. ठीक है? और metaplasia goblet cell के साथ हो रहा है, तो intestinal type of क्योंकि goblet cells are present in intestinal mucosa, it appears to be like an intestinal mucosa. Hence this whole phenomena is what we call it as intestinal type of metaplasia. This is what we call as intestinal type of metaplasia. This is what we call it as the intestinal type of metaplasia, right? So the squamous epithelial cells is converting into the columnar epithelial cells along with the goblet cells, and this whole conversion is what we call it as the intestinal type of metaplasia. Remember, dysplasia is irreversible, metaplasia is usually reversible. Metaplasia is usually reversible, right? Now, how would a patient present to you? The clinical features of Barrett's esophagus. The clinical features of Barrett's esophagus. The clinical features of Barrett's esophagus, nothing spectacular about it. It is going to be same as GERD. This is going to present as same as GERD because Barrett's is not a disease, it's a complication of an untreated GERD. Okay? So whenever a patient has a long-term GERD, I would like to investigate this. So when you're trying to talk about investigation, so when you're trying to investigate the GERD, the investigation, so we'll talk about the investigation of GERD first, and then we'll talk about the investigation of Barrett's esophagus. So in the investigation of GERD, whenever you're suspecting a patient with GERD, the first investigation will be a 24 hours pH monitoring. There will be a 24 hours pH monitoring. The first thing that you're going to do is going to be a 24 hours pH monitoring. Okay? Now, once you have done with 24 hours pH monitoring, the other ones that you have is a 48 hours ambulatory pH monitoring. So get more data. You have 48 hours ambulatory pH monitoring. So you have 24 hours pH monitoring, 48 hours ambulatory pH monitoring. Along with that, you can also do that is called as impedance pH monitoring. So when you do an impedance pH monitoring, or you can say the ambulatory impedance pH monitoring, we measure something called as the D-Meester score. Okay? So itna yaad rakhna, whenever we're talking about a D-Meester score, if a D-Meester score is more than or equal to 14.7, it is confirmatory of GERD. इतना ही लिखना है, ठीक है. So 24 hours pH monitoring, 48 hours ambulatory pH, impedance pH monitoring. Along with that, I will do an upper GI endoscopy. Now, in the upper GI endoscopy, it is very important because जब आप upper GI endoscopy करोगे, इतना याद रखना, in an upper GI endoscopy, if you find there is presence of red velvety mucosa. If there is presence of red velvety mucosa, it points towards Barrett's esophagus. It points towards Barrett's esophagus. So whenever there is a red velvety mucosa present, remember in this upper GI endoscopy, with biopsy should be performed. The reason why you want to do biopsy is, remember, in Barrett's esophagus increases the risk for adenocarcinoma of the stomach. It increases the risk for adenocarcinoma of the stomach. To rule out the adenocarcinoma of the esophagus, not the stomach. It increases the risk for adenocarcinoma of the esophagus. Now, to rule out the malignancy, you should always perform biopsy. Now, on a biopsy, once you've done the biopsy, if it is positive for Barrett's, esophagus, here the management for Barrett's esophagus, it is to treat GERD. So as I told you, Barrett's esophagus is not a disease, it's a presentation of an underlying disease. So even if you diagnose this as Barrett's, the management will still refer it to the treatment of GERD only. Okay? So we started with the clinical, what is GERD? What are the causes for GERD? What are the clinical features that you can see? What are the extra GI manifestations? What are the complications associated with GERD? How would you like to investigate it? How would you see as a Barrett's esophagus? And all these can be taken care of. Now comes the workhorse, that is the management of GERD. So when we talk about the management of GERD, in the management of GERD, the first line management, it is going to be medical management. It is going to be a medical management. So in the medical management, what are you going to give? Number one, I'm going to prescribe the patient with proton pump inhibitors. Now the PPI should be given. Along with proton pump inhibitors, I will advise for lifestyle modification. Now in the lifestyle modification, I would ask the patient to reduce weight, quit smoking, no alcohol and all that, and then regulate the diet also. In the regulating the diet, I will advise the patient to take small, frequent feeds, not to load the stomach. Right? So it is going to be your proton pump inhibitors, lifestyle modifications, as well as small frequent feeds. All these should be taken as medical management. Now, if the medical management fails, that means patient is still symptomatic, then you would go down to the second line management. Now, the second line management, it is going to be surgery. So how would you actually make a decision for surgery? So what are the current indications for surgery? Now the current indication for surgery, number one, not responding to medical management. That means even after starting proton pump inhibitors, even after starting the proton pump inhibitors and lifestyle modification, patient is still symptomatic, consider for surgery. Number two, if there is development of Barrett's esophagus, if there is esophageal stricture, if it develops into hiatal hernia, that is a sliding hiatal hernia, right? So not responding to medical management, Barrett's esophagus, presence of stricture, or any evidence of hiatus hernia, this is where you have to go with surgery. Now, in the surgery, what surgery are you going to prefer? It is going to be an anti-reflux surgery. So in an anti-reflux surgery, it is usually done as fundoplication. It is performed as fundoplication. So in the fundoplication, what are we going to do? So what you're going to do is, if this is the esophagus, I have to strengthen the sphincter. So this is the stomach that is present. So we will wrap the stomach. So this is stomach that you have. So I've taken the fundus of the stomach and I have pulled it. Right? I've taken this fundus of the stomach, I have rotated around the esophagus, and then I am at stomach again. Okay, I'm just going to suture at this end. Right? Now this surgery where you're taking the fundus of the stomach, this is the fundus of the stomach, and this is encircling the esophagus. This is the fundus of the stomach. It is encircling the esophagus, and once it is there, I'm going to suture this at this end. I'm going to suture the esophagus to stomach, and this surgery is what we call it as Nissen's fundoplication. This is what we call it as Nissen's fundoplication. Nissen's fundoplication. When you look at this, it is going from behind, so it is a posterior. It is encircling the entire circle completely, so it is called as complete. It is a posterior complete fundoplication. It's a posterior complete fundoplication. Right? So this is your Nissen's fundoplication. बेटा आदित्य इसमें कोई मतलब you don't need to learn because when you see the patient on a daily basis, इतनी बातें होती हैं patient से, इतनी चीज़ें बताता है. As a curious soul, no. As a surgeon, as a doctor, as a clinician, no. जब भी आपके पास कोई patient आके कुछ बताता है तो you need to find the answer कि क्यों हो रहा है. And once you understand it, no, उसका it sticks to your head. So this entire thing that I've told you, no, it's about my patients. ठीक है, जब patient को आप देखोगे तो बेचारा क्या complain लेके आएगा. Patient आपके पास आएगा कि डॉक्टर साहब ये सब problem हो रही है. जब ये प्रॉब्लम हो रही है तो आपको पता है कि अगर ज़्यादा दिनों से हो गए तो ये भी हो सकता है. अगर ये हुआ तो कॉम्प्लिकेशंस में ये देखने को मिलता है. अगर ये कॉम्प्लिकेशन होगा तो आप कैसे इन्वेस्टिगेट करोगे, आपको आपका प्रोटोकॉल पता होना चाहिए. इन्वेस्टिगेशन में फाइंडिंग क्या मिलेगी, फाइंडिंग के हिसाब से मैनेजमेंट क्या करनी है, मैनेजमेंट में सर्जरी करनी है. सर्जन अगर सर्जरी नहीं करेगा तो क्या करेगा. ठीक है भाई, ये सब तो मतलब दिस इज लाइक योर लव यार, ये पैशन है. ठीक है, तो इसमें कोई याद रखने वाली बात नहीं होती है. जिस चीज़ से प्यार होता है वो अपने आप याद रहती है, टेंशन नहीं लेना. ठीक है, सो आई जस्ट वांट यू टू अंडरस्टैंड. सो दैट इज व्हाई इफ यू अंडरस्टैंड, इफ यू रियली डिग इनटू द कॉन्सेप्ट्स ऑफ मेडिसिन, नो देयर इज नथिंग लाइक इट. मतलब उसका नशा ही अलग है. चलो, सो नीसेस फंडोप्लाइकेशन में क्या होगा, आप स्टमक को पीछे से लेके आ रहे हो. सो इट इज अ पोस्टीरियर कंप्लीट फंडोप्लाइकेशन. व्हाट आर द अदर एग्जांपल्स और अदर फंडोप्लाइकेशंस दैट यू हैव? The other examples of the fundoplication that you have, it is going to be door, then there is stopet, and there's door fundoplication, there's stopet, there's Watson. Right? So different fundoplications are present. ठीक है, just for the name sake इतना याद रख लो, more than important है. अच्छा, फिर अगर आपके एग्जामिनर को इम्प्रेस करना है, what are the new techniques or the new methods? New methods में number one, you can go with RFA, that is radio frequent ablation. Number two, there is a device called as the Lynx device. Lynx is a magnetic bead. It's a magnetic bead device. Then you have Esophagus. Esophagus is an endo GI stapler. ठीक है. So radio frequent ablation you can do it. You can do a links which is a magnetic bead. तो मतलब वो magnet का bead का जो rim होता है ना वो esophagus के ऐसे लगाते हैं, right? So it is going to hold the esophagus tight. So every time you swallow, because the magnet attract with each other, they compress the esophagus. That is going to be a links device. Esophagus is an endogenous stapler. You take and you staple the fundus with the posterior wall of the esophagus so that it adheres and again increase the tone. So all these concludes in that particular context. Okay? So this is how you're going to talk about your entire GRD. Clear hai? Sorted. Okay? So did we cover all the questions? Let's look at the quick component here. कहाँ गया अपना सवाल? तो हमने कवर कर लिया है जी, GRD कर लिया है, Barrett's esophagus भी कर लिया है. ठीक है. Now coming to another very important topic, that is going to be esophageal virus. तो तीनों एक ही में कवर कर लेंगे. Esophageal viruses, tips और upper GI bleed and its management. ठीक है. Clear? So far any questions? कोई सवाल, कोई शक, कोई डाउट? Quick feedback. कोई सवाल, कोई शक, कोई प्रॉब्लम? Going good? समझ में आ रहा है? I hope so. चलो, so we'll talk about the upper GI bleeds and we'll talk about esophagus. पेज खत्म हो गया क्या? कोई ऐड कर लें? चलो. So we'll talk about the upper GI bleeds. So the next question is going to be upper GI bleed. So in order to conclude what you're talking about, GI bleeds का जो classification है, so we talk about the GI bleed. GI bleed is categorized into the upper and the lower GI bleed. ठीक है. So they're classified into two components. We have the upper GI bleed and then you have the lower GI bleed. You have the upper GI bleed and the lower GI bleed. ठीक है. So how do you know कि what is an upper and what is a lower GI bleed? Any bleed in the GI lumen, above the ligament of teats, is what we call it as an upper GI bleed. Same thing validates for lower GI bleed. Any bleed in the GI lumen, below the ligament of teats. That's a hepatoduodenal ligament. No? Below the ligament of teats is what we call as lower GI bleed. Okay? So when we talk about the GI bleeds, we categorize them. I mean, the causes for the upper GI bleed, we can categorize them into two major causes, right? Talk about the cause for upper GI bleed. So we're going to talk in two different categories. One we call it as the variceal bleeding, another one is your non-variceal bleeding. One we call it as the variceal bleeding. Another one is non-variceal bleeding. Now why I'm differentiating into two different categories is variceal bleeding is of significant quantity, right? Whereas the other ones can be of different context as well. So when talk about the variceal bleeding का जो cause it is because of esophageal varices, right? So this occurs because of esophageal varices. So we'll talk about the reasons for esophageal varices. For now, it is this. Now, what is more interesting is going to be your non-variceal bleeding. Now, in a non-variceal bleeding, there's a huge spectrum of the disorders that we should be knowing it. So, in a non-variceal bleeding, one of the most, repeatedly formed questions that you will see, it is going to be associated with erosive gastritis. It can be seen secondary to erosive gastritis. It can be seen secondary to peptic ulcer disease. It can be seen secondary to gastric cancer. It can be seen to secondary to gastric carcinoma. Then you have other causes like Mallory Weister. It is associated with Mallory Weister. It is associated with that of the Mallory Weister. Mallory Weister. It is associated condition like GAVE, that is your gastric antral vascular ectasia. Gastric antral vascular ectasia. Also, sir, Delafoy's gastric lesion is also associated with Delafoy's gastric lesion. Right. So these are the various causes for your variceal as well as non-variceal bleeding. Okay. Now, we're talking about the esophageal varices first, and then we'll go into the non-variceal bleeding causes as well. Okay. Now, the first one is going to be your esophageal varices. So the question that we're going to discuss here is going to be about esophageal varices. So the esophageal varices, when you talk about it, the cause for the esophageal varices is going to be portal hypertension. So when you talk about what is an esophageal varices, esophageal varices is described as these are dilated submucosal, dilated submucosal vascular plexus due to portal hypertension. So the dilated submucosal vascular plexus due to portal hypertension resulting in significant upper GI bleed. Okay. So dilated submucosal vascular plexus due to a portal hypertension resulting in significant upper GI bleed. Now, to understand the whole concept, you need to understand what is portal hypertension. Now, to understand the whole concept of portal hypertension, remember the normal portal pressure. The normal portal pressure, it is going to be 1 to 5 millimeters of mercury. Then there's something called as pre-portal hypertension. That is going to be 6 to 9 millimeters of mercury. Now, after pre-portal, then you have portal hypertension. Portal hypertension is described as pressure of more than or equal to 10 millimeters of mercury. So when would you have bleeding in esophageal varices? So bleeding in varices occurs when there is more than or equal to 12 millimeters of mercury pressure. Right. So these are the pressure that you remember. The normal portal pressure is 1 to 5, pre-portal is 6 to 9, portal hypertension is more than or equal to 10, bleeding in the varices occur when there is more than or equal to 12 millimeters of mercury. So what are the causes for portal hypertension? So the next thing that you need to know is the causes of portal hypertension. Now when we talk about the causes for the portal hypertension, now the causes for the portal hypertension is divided into various components, right? So when we talk about the various components, let's have a quick recap on that as well. Now take this as the representation of the liver. So when you take this as the representation of the liver, you will notice that this is the portal vein. You have the right portal vein and then the left portal vein. So this is your the right portal vein, the left portal vein, together they form the common portal vein. Now this portal vein per se is formed by the splenic vein and the superior mesenteric vein. The splenic vein will be combined with your inferior mesenteric vein, and all this blood is now going to flow into the portal vein. Apart from that, you will see that the inferior vena cava, which is going to run behind the liver, so this is the side where you see the IVC is present. Apart from that, you'll also notice that the left hepatic vein, the middle hepatic vein, and the right hepatic vein, they all drain into inferior vena cava. This is the basic concept that you have, right? So if I simply label every single thing that we have drawn here, this becomes your splenic vein. This becomes your inferior mesenteric vein. This forms your inferior mesenteric vein. This is your superior mesenteric vein. This happens to be your portal vein. This happens to be your inferior vena cava. These are your hepatic veins. This is your right hepatic vein. This happens to be your middle hepatic vein. And this happens to be your left hepatic vein. So the blood from the splenic vein, from the inferior mesenteric vein, they all flow from the superior mesenteric vein, they all flow into the portal vein. From the portal vein, the blood goes into the liver. Now from the hepatic veins, the blood is going to be now ejected into the inferior vena cava. From the inferior vena cava, it is now going to go into the systemic circulation. Which is better, MCH neurosurgery or MCH GI surgery? Please anyone respond. Beta, you are in a UG class. You are asking about MCH. So I'm thinking that you have done with your MS general surgery. Now if you are either doing your MS general surgery or you are into your MS general surgery and you're thinking about which one to pick, whether to take a neuro or a gastro, they're two different spectrums altogether. Now, neuro has a different line of work, GI has a different line of work, neuro is more with emergencies, GI is, there are emergencies but less emergencies are there, the line of work, the handling of tissue, everything matters and differs, right? So, see, choosing a super specialty branch is something is going to be very personal. You need to go see that department, work there for a few months and see which suits you better. Like, do you have a better, orientation and a better acumen towards GI? Go with GI. If not, if you feel, see, don't go with the hype, that the neuro surgery and then you enter it. No, if you really love neuro, go, right? So a lot of things that are associated, like the morbidity and the mortality in neuro is high, the morbidity and mortality in GI is relatively less. You'll have, your patients are much more happier when it is on a GI spectrum, and the morbidity on the neuro part is much more longer. And if you're able to deal with that, why not? See? So all that is going to be taken into consideration. Clear? Now, when we talk about the cause of portal hypertension, we're talking about the pressure in the portal vein is going to increase, right? So when you talk about the pressure in the portal vein is going to increase, you need to know where exactly the cause is. So this is going to be the liver, right? This is your left portal vein, the right portal vein, the common portal vein, superior mesenteric vein, splenic vein, inferior mesenteric vein, and it continues off. This happens to be your inferior vena cava. Right. What we do is we are now going to segregate the causes into three spectral components. One, before entering into the liver, we'll be calling it as pre-hepatic cause. We'll see what are the causes which are present in the liver. We call it as the hepatic cause. And the causes that is going to be after exiting the liver, that is a post-hepatic cause. Good evening, sir. I'm in third year. I mean, just second year ended. I'm your huge fan of the Bailey series, and then hoping something great again like Shushita batch for the third year. Right, thank you so much for such a kind word. We will continue Bailey in Love series, बेटा BLS हम तब तक चलाएंगे जब तक हम अपनी Bailey खत्म नहीं कर देते, ठीक है? So that's a promise. So we will continue to do Bailey. Bailey रोकने का सवाल ही नहीं होता, ठीक है? In between you will have series like Farre. We'll also do, you know, a private, that is Shushita batch 4th year का और live batch भी start हो जाएगा. We'll do all that. That all is going to be into consideration. But Bailey नहीं रुकेगी, ठीक है? BLS is something that I want to do it for myself, because I see a huge potential for, you know, medical students all across the world. And I'm telling you again and again, the single best source for surgery, if you want to read, it is going to be BLS, ठीक है? हम उसको ऐसा बना ही देंगे कि कल को, you know, लाइफ में अपग्रेड भी हो जाए और कभी कोई सर्जरी में डाउट हुआ ना, तो BLS में आपको उसका जवाब मिल जाएगा. That's a promise, ठीक है? तो BLS is going to be an evergreen series. We will do it. We are not going to halt it at any single cost. करके ही रहेंगे, ठीक है? चलो. Now, let's talk about the causes of the portal hypertension. So I'm just continuing on the same spectrum. Talking about the causes of the portal hypertension. So as I've divided them into three distinctive components. So जो भी cause इस line में होगा, it is what we call it as the pre-hepatic cause. So here it is going to be pre-hepatic cause. This will be the hepatic cause. And here it is going to be the post-hepatic cause. Right? So you have the pre-hepatic cause, the hepatic cause, and the post-hepatic cause. Now, pre-hepatic cause, in a pre-hepatic cause, what are the components that you have? In a pre-hepatic, see, the whole concept here is, when you talk about portal hypertension, due to XYZ जो भी reason होगा, portal vein में pressure बढ़ रहा है, ठीक है? अब किसी भी वेसल में प्रेशर क्यों बढ़ेगा? सिंपल सा कॉन्सेप्ट है कि अगर यहाँ पे ब्लड ज़्यादा पूल होने लगा, सो द होल आइडिया दैट वी आर ट्राइंग टू बिल्ड अप हियर, कि ये पता करने के लिए कि इस वाले वेसल में ना प्रेशर क्यों बढ़ रहा है. किसी भी वेसल में प्रेशर दो ही चीज़ों से बढ़ता है, या तो वॉल्यूम ज़्यादा हो रहा है या तो वेसल छोटा हो रहा है. दैट्स इट. Either the volume in the vessel is increasing or the size of the vessel is decreasing, and that is where a pressure inside a vessel would increase, resulting in portal hypertension or any hypertension per se. तो अब हमको ये देखना है कि ऐसी कौन कौन सी चीज़ें जो यहाँ पे आपकी प्रेशर बढ़ा सकती हैं, by either increasing the volume of the blood, or either it is going to increase the volume of the blood, or it is going to result in, or it is going to result in decreasing the size of the volume, right here. So number one is going to be portal vein thrombosis. Imagine karo if a patient is having a portal vein thrombosis. If there is a portal vein thrombosis. So when we talk about the portal vein thrombosis, simple sa concept kya portal vein thrombosis mein, if there is a thrombus that is going to be formed in the portal vein, if there is a thrombus that is going to be drawn, present in the portal vein, the size of the portal vein is getting smaller, so obviously the pressure is going to increase. Okay? Along with portal vein thrombosis, imagine if there is any tumor that is going to encircle, right? That is what we call it as the malignant occlusion. If there is malignant occlusion of the portal vein, if there is a malignant occlusion of the portal vein. So either there is presence of portal vein thrombosis, or there is a malignant occlusion of portal vein. In a malignant occlusion of portal vein, you can see a tumor that is going to grow and it is going to encircle the portal vein. Like अगर पोर्टल वीन को पूरा एनकेस ही कर देता है, एनकेसिंग द पोर्टल वीन एंड कंप्रेसिंग द पोर्टल वीन, एंड दैट एनकेसिंग और कंप्रेशन ऑफ द पोर्टल वीन विल इंक्रीज द प्रेशर इन द पोर्टल वीन, ठीक है, तो दबा दिया। सो एक हो गया पोर्टल वीन थ्रोम्बोसिस, एक हो गया मैलिग्नेंट ओक्लूजन ऑफ द पोर्टल वीन। Along with that, it can also result from a parasitic condition called as schistosomiasis. Schistosomiasis mein you will see there is this parasite which is going to go sit in the portal vein. Now when it sits into the portal vein, it causes an inflammation, chronic inflammation बनता है, and because of that chronic inflammation there will be fibrosis or there will be edematous component here, not allowing the blood to go into this vein. तो क्या होगा, ज़्यादा पूरा blood यहीं पे पूरने लगा, अब blood जा ही नहीं पा रहा, blood is not able to go into this vein. What is going to happen, जो भी जाएगा इधर जाएगा, rest of the blood will start pooling into the portal vein, resulting in back pressure, and that is going to result in portal hypertension. So portal vein thrombosis, malignant occlusion, schistosomiasis. Another condition, if I just want to complete the list, that is secondary to your congenital hepatic fibrosis. Congenital hepatic fibrosis. All these will result in prehepatic cause for resulting or development of portal hypertension. It is going to be a portal hypertension, right? Now when you talk about the hepatic cause, now in the hepatic cause, it is secondary to liver cirrhosis. Let it be any reason for liver cirrhosis, XYZ, ultimately it is going to result from liver cirrhosis. Ab liver cirrhosis, the concept is quite simple. If the liver is going to get damaged, now imagine if the liver is getting damaged, what is going to happen? The blood that is going to come from the portal vein has to go into the liver. Ab liver damaged, तो blood कहाँ जाएगा? जा ही नहीं पा रहा, blood बोल रहा जाऊँगा, liver बोल रहा है मैं ठीक नहीं हूँ, मैं लूँगा ही नहीं blood. तो all that blood will start pooling back into the portal and resulting in back pressure, resulting in portal hypertension. Next comes is your post-hepatic cause. In the post-hepatic cause, you have a veno-occlusive disorder, example like Budd-Chiari syndrome. So Budd-Chiari syndrome में there is blockage of hepatic vein. अगर hepatic vein block हो गया तो blood liver से बाहर जा ही नहीं पाएगा. अगर blood बाहर नहीं जा पाएगा तो blood will start pooling inside the liver, back pressure, then into the portal vein, resulting in portal hypertension. So any not only Budd-Chiari syndrome, any other form of veno-occlusive disorder. Any other form of veno-occlusive disorder. So Budd-Chiari syndrome and the veno-occlusive disorders are the post-hepatic cause. Okay? So these are the causes that results in portal hypertension. Three different segments: pre-hepatic, hepatic, and the post-hepatic causes for portal hypertension. Okay? Now once you know the causes, let's understand that how does the varices are formed, the pathophysiology of varices. Pathophysiology of varices. So the varices are formed because of development of portosystemic collateral. So the magic word to remember here is it is due to the development. It is due to the development of portosystemic collateral circulation. It is because of portosystemic collateral circulation. It is because of portosystemic collateral circulation. सर आप क्या सर्जरी करना सिखाओगे? बेटा जिस दिन आप जनरल सर्जरी कर लोगे आ जाना मेरे पास, बिल्कुल सिखा देंगे, ठीक है. यू नीड टू बी क्वालिफाइड इनफ टू लर्न सर्जरी बेटा, ठीक है, ऐसे ही थोड़ा सर्जरी सिखा देंगे. सर व्हाट इज द डिफरेंस बिटवीन पेप्सिन एंड ट्रिप्सिन? हाय काश मैं आपको ये डिफरेंस बता पाता कि पेप्सिन और ट्रिप्सिन में फ़र्क क्या होता है. देखो ये चीज़ें आपको आपका बायोकेमिस्ट्री और मेडिसिन वाले ज़्यादा बता पाएंगे. देखो हम सर्जन ना बड़े सिंपल होते हैं यार, ठीक है. एज अ सर्जन ना हमारा इतना दिमाग चलता नहीं है. अगर इतना दिमाग होता तो मेडिसिन लेके हम भी मेडिसिन कर रहे होते हैं. सर्जरी वालों को इतना ही पता है कि बेटा बेसिक ये पैरामीटर्स हैं और ये एनाटमी है, यहाँ पे प्रॉब्लम है, ये काटा वो जोड़ा, अपना काम खत्म, ठीक है. सो पेप्सिन ट्रिप्सिन लाइपेस यार ये सब आपको अपने बायोकेमिस्ट्री वाले सर हैं, मेडिसिन वाले हैं, उनसे आराम से पूछिए यार. हमसे पूछिए कि सर जीजे क्या होता है, पूछिए कि सर रूएनवाई क्या होता है, ठीक है, जो मर्जी पूछे बताएंगे सर, ठीक है. चलो अभी तक पैथोफिजियोलॉजी ऑफ वायरसेस सुनिए सर. वायरसेस बन कैसे रहे हैं, फूट कैसे रहे हैं, ब्लीड कैसे हो रहा है, ये बताएंगे आपको. So in the pathophysiology of varices, now you take this as a representation of the abdominal wall, मान लेते हैं, ठीक है. So let's say this happens to be the esophagus, this happens to be the stomach, this happens to be the duodenum, let's say this happens to be the jejunum goes into ileum, the ileum goes into appendix, into cecum, ascending colon, transverse colon, descending colon, ठीक है. So we have the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, rectosigmoid, and then to the anal canal, ठीक है. अच्छा. Then you have this area which is guarded by diaphragm, which is here. Then let's say this is the liver that we have. So ये हमारा liver के territory हो गया, ठीक. This is the liver that you have. Just for sake of understanding, let's say this happens to be the umbilicus. पीछे vertebra मान लीजिए, ठीक है. These are the vertebrae that are present. So these are your lumbar vertebra. Just for the sake of discussion, these are your lumbar vertebrae, ठीक है. The cover that is going to be present throughout is what we call it as the peritoneal cover. So this is the peritoneum, which is separating the intra-abdominal content from the other one. So this is the peritoneal cover that is present, ठीक है. Now portal hypertension में there will be portosystemic collaterals which are going to be formed. Let's say this happens to be the portal vein that we're talking about. So जब pressure बढ़ने लगता है ना, when the pressure will start increasing inside the portal vein receives the blood from multiple sides, ठीक है. तो अब क्योंकि blood liver में जा नहीं पा रहा portal vein से, तो portal vein will try to find alternate routes so that it can send the blood back into the circulation. तो पहला alternate route वो बनाएगा आपके esophagus के साथ. तो esophagus में जब blood pool होने लगेगा तो इसमें यहाँ पे varices will start to form. So the first is going to be the first portosystemic collateral is formed with the esophageal veins. It is formed with the esophageal vein. The second portosystemic collateral will be formed with the bare area of the liver. तो liver के पीछे ही एक area होता है where there is no capsule. This is called as the bare area of the liver. तीसरा वो बनाएगा आपके umbilicus के around. So you will see that multiple blood vessels are found dilated around the umbilicus. And this dilated blood vessel around the umbilicus is what we call it as caput medusae. So the third portosystemic collateral is here. The fourth portosystemic collateral, you will see, देखिए इसके ऊपर ना, on the greater curvature of the stomach, you have this layer, and this is what we call it as the omentum. So this is the omentum that is arising from the greater curvature of the stomach. This is from the greater curvature of the stomach. So you will see that these portosystemic collaterals will be formed with the omental veins. So you will see there will be omental veins पे एक और portosystemic collateral बना हुआ है, ठीक है. So how many do you have? The first one is this, the second one is here, third one is here, fourth one is here. The fifth portosystemic collateral will be found behind the peritoneal surface. So in the retroperitoneal veins, you have the fifth portosystemic collateral. So this is your retroperitoneal vein. Then you will also see that it is going to be formed. You will say it is also going to be formed with your lumbar veins. So it goes here. So with the lumbar veins also, it is going to develop into portosystemic collateral. So in the lumbar veins also, you have the portosystemic collateral. This is the sixth one. And the last one, which is quite important, this is going to be with the anal canal. So when it forms with the anal canal, it is going to result into internal hemorrhoids. Right, so 7th portosystemic collateral is going to be with the hemorrhoidal veins. Okay. So there are 7 portosystemic collaterals which are formed. I'll just quickly label them also. The first one that we said is going to be your esophageal veins. It is going to be your esophageal vein. Second one is going to be in the bare area of liver. It's going to be in bare area of the liver. The third one is going to be with the periumbilical veins. It is going to be in the periumbilical veins. The fourth one is going to be with the omental vein. The fourth one is going to be the omental vein. The fifth is going to be retroperitoneal veins. It is going to be the retroperitoneal vein. Sixth one, it is going to be with the lumbar vein. And the last one that you have is going to be with the hemorrhoidal vein. So when the portal vein is going to get blocked and the blood is not able to go any further, you will find that there are 7 different sites from where the blood can be given back into the systemic circulation, and this is what we call it as the portosystemic collaterals. Now, even though there are 7 different sites, no, to be very honest, you only have 3 sites which are going to produce symptoms, right? The 3 sites which are going to produce symptoms are going to be your esophageal veins, the periumbilical veins, and the hemorrhoidal veins. Your esophageal veins is going to present to you as bleeding esophageal varices. They're going to present to you as bleeding esophageal varices. Okay? Periumbilical vein will present to you with dilated veins, and this is what we call it as the caput medusae. The caput medusa is nothing but, it, around the umbilicus there's all dilated veins. So medusa ke hair ki tarah you will see all that is going to present. That is called as caput medusae. And in the hemorrhoidal veins, it is going to present to you as bleeding internal hemorrhoids. It is going to present to us bleeding internal hemorrhoids. It is going to present to you as bleeding internal hemorrhoids. So you have the bleeding esophageal varices, you have the caput medusae, and the bleeding internal hemorrhoids. Clear? So these are the one. If they ask, what is the, just to mention it, remember the most common clinical presentation. The most common clinical presentation of bleeding of portal hypertension is going to be bleeding esophageal varices. It is going to be the bleeding esophageal varices. This is going to be a bleeding esophageal varices. The most common clinical presentation for the portal hypertension, it is going to be your bleeding esophageal varices. Clear? Okay. Now everybody is clear with how the upper GI bleed is classified. What are the causes? How does the esophageal varices formed? What is the concept of portal hypertension? What are the causes of portal hypertension? Then what is the pathophysiology of varices formation by developing into a portosystemic collateral? What are the different sites for the portosystemic collaterals, right? Now let's talk about the management of the bleeding esophageal varices. Management of bleeding esophageal varices. When we talk about the management of the bleeding esophageal varices, it's a protocol based approach, so we'll try to keep it in the same context. ठीक है बेटा, डायरेक्टली बीटा ब्लॉकर नहीं देना ना, पहले आपको सोचना है, देखना है, एसेस करना है. हर अपर जीआई ब्लीड आपका पोर्टल हाइपरटेंशन से नहीं होता ना, so just let's have some common sense about it. So any patient who is going to have bleeding esophageal varices, he is going to present to us with upper GI bleed. So patient की जो presentation होगी, it is going to be with upper GI bleed. ठीक है? Now here's an interesting thing that you need to understand. I've seen a lot of patients with portal hypertension with esophageal varices. When they come, when they start throwing up blood, when there is a lot of, hematomesis that is going to occur, it is not going to be in a small kidney tray or a small bowl. You give a bucket because that's how the extensive the vomiting would be. मैंने काफी patients देखे हैं, especially coming from a rural background, no, उनके attendants को पता नहीं होता करना क्या. They would have stuffed their mouth with the entire towel. जैसे towel निकालोगे, it is drenched in blood. ठीक है? तो ऐसे patient जो upper GI bleed के साथ आपके पास land हुआ ना, तो मेरा यहाँ पे ऑब्जेक्टिव ये नहीं है कि डायग्नोसिस बनाना है, मुझे स्टेबलाइज करना है. सो द फर्स्ट स्टेप, सो द स्टेप नंबर 1, इट इज टू सिक्योर 2 large IV cannula. It is to secure 2 large IV cannula. Start the patient on IV fluids, usually starting with ringer lactate. Start the patient on ringer lactate. Right, so secure 2 large IV cannula, start the patient on IV fluids, maintain the systolic blood pressure should be more than 80 millimeters of mercury. Systolic blood pressure should be of more than 80 millimeters of mercury, and then you can give vasoactive drugs also, right? you can give vasoactive drugs. So as an initial shot of vasoactive drug, you can have somatostatins and all that. Right. So you give 2 large IV cannulas, start the patient on ringer lactate, give more than 80 maintain the systolic blood pressure more than 80 millimeters of mercury, and if required, give vasoactive drugs also. Once you started to give fluids and resuscitate, you will notice whether the bleeding is persistent or not. So once you have done this, you have to see whether the bleeding. So we'll try to assess the status of bleeding, whether it is present or absent. So you will notice the status of bleeding if it is present, or if the status of bleeding if it is absent. Right? If it is absent, good. If bleeding is still present, if the bleeding is still present, I have to stop the bleeding. Right? So in order to secure and try to stop the bleeding, so I've started with the IV fluids, I have gone with the resuscitative protocol, and the bleeding continues to happen. If the bleeding continues to happen, I can consider here for blood transfusion, and at the same time I can also consider for the drugs which are going to stop. Right? So here I can okay, when you talk about, there are a lot of if and but that what drug should be given. The somatostatin that you have given here is your octreotide. So somatostatin analog, that is octreotide. So here if the bleeding continues to happen, you can repeat the injections of octreotide. Injections of octreotide. You can also give terlipressin. You can also give drugs like terlipressin in order to control the bleeding. Now, even after doing these two, right, you have tried blood transfusion as well as terlipressin. If bleeding continues to happen, then you have to go with a protocol which is called as a balloon tamponade. You have to go ahead with balloon tamponade. Now, what is this balloon tamponade is? It is basically to exert pressure and stop the bleed, right? So how are you going to achieve this, right? So there is a balloon which is called as a Sandeep-Blakemore tube. I'm going to insert the Sandeep-Blakemore tube into your stomach, right? So if this is the esophagus here, now this is the SBT tube that goes in, and this Sandeep-Blakemore tube has 2 balloons. One is called as the esophageal balloon, which are going to inflate here. Another one is the gastric balloon, which are going to inflate here. Now, because the varices which are going to be arising, they are going to arise from the lateral wall. So when these balloons are, inflated, they exert pressure onto the lateral wall. And when they exert pressure onto the lateral wall, the bleeding will stop. It's as simple as that. So balloon tamponade can be tried in order to, for controlling the bleed. And this is done with the help of a tube that is called as the Sandeep-Blakemore tube. Now, in the Sandeep-Blakemore tube, you can see there are 2 balloons. This is your esophageal balloon. Now, the esophageal balloon, when you are going to inflate, the esophageal balloon, it is going to be inflated with air, and this is going to be inflated with 40 millimeters of mercury pressure. This is what we call it as the gastric balloon. So when you talk about the gastric balloon, it is also inflated with air, but this time it is going to be inflated with 300 ml. So the volume of air which is going to be pumped in here, right? So balloon tamponade will be tried in order to stop the bleeding, right? Now, by hook or crook, once the balloon tamponade is done, I would be able to achieve that the bleeding is going to come to a halt. Here we are going to see that the bleeding is going to come to a halt, right? Now, when the bleeding controls, right, if the bleeding controls, so after balloon tamponade, again there are 2 components. Either the bleeding will continue to happen, or if the bleeding continues, or stops. If bleeding continues to happen or persistent or rebleed is there, here the only thing that is going to be your surgical intervention. We'll talk about it. What is the surgical intervention? If it continues to bleed, then you have to bypass, shunt create करके blood को देखना पड़ेगा. Now, if bleeding stops, I would now want to know that why did it bleed in the first place. So we have done two-step method. No, the step 1 is going to be this, and if the bleeding continues, this is your step 2 protocol. Okay. Now we are moving to step 3. Step 3 is evaluation. So in step 3, I want to know that where did it bleed from, right? So in order to know this, I'm going to perform an upper GI bleed. Okay. So upper GI endoscopy. I'm going to do an upper GI endoscopy to know from where the bleeding was occurring. As simple as that. Now, जैसे मैंने upper GI endoscopy किया, I'll be able to find that there is presence of esophageal varices. ठीक है? So once you do an upper GI endoscopy, remember before doing an upper GI endoscopy, remember you have to perform a gastric lavage. This gastric lavage should be done with normal saline, right? Now this lavage should be done with a room temperature normal saline, because if you use warm, it will cause vasodilation and bleed, and if you use cold, it causes platelet dysfunction. So gastric lavage should be performed at room temperature normal saline and then do an upper GI endoscopy. Now once you have done an upper GI endoscopy, you will identify the source, that is going to be your esophageal varices. The step 4 is what we call it as, it is going to be your EVL. EVL stands for endoscopic variceal ligation. It is your endoscopic variceal ligation. It is going to be an endoscopic variceal ligation. That means it's nothing but banding. So the EVL endoscopic variceal ligation, this is also known as variceal banding. This is also known as variceal banding. Okay. Now if it reoccurs even after banding, so if it rebleeds after EVL, then you have to go ahead with surgical intervention. So this is an indication that you have to take the patient for intervention. So in an intervention, the ideal intervention that we have as of today is what we call it as TIPS. Now TIPS stands for transjugular. It is transjugular intrahepatic. It is a transjugular intrahepatic portosystemic shunt. Portosystemic shunt. It is a transjugular intrahepatic portosystemic shunt, and that is what we call it as TIPS, right? Now, what do you do by TIPS? So the basic objective of the TIPS is you take this as a representation of the heart, right? It is divided into 4 chambers. Take this as a representation of liver, and here where the problem is, portal hypertension is happening, right? So what you're going to do is, this is your left portal vein, this happens to be your right portal vein, and this continues here. On the other hand, this is going to be your right hepatic vein, the middle hepatic vein, and the left hepatic vein. Together, they all combine together to form inferior vena cava. So this is the IVC which is going here. It opens onto the right side of the heart, right? So this is what is happening. Now, here it is your superior vena cava which is here. It is going to be into the right and the left jugular vein. So this is the right jugular vein. This happens to be your left jugular vein, right? So this is the whole objective. So this happens to be your right atria. This is your right ventricle. This is your inferior vena cava. This happens to be your right hepatic vein, and this happens to be your right portal vein. In the TIPS, I'm going to go ahead with right jugular vein. So what we do is, we take a guide wire. We cannulate the right jugular vein. I'm going to go into the right atria. From the right atria, I'll go into the IVC. From the IVC, I'll go into right hepatic vein. From the right hepatic vein, I'll go into right portal vein. Once I reach to the desired site, now I'm going to deploy my stent, and the stent will be placed between the right portal vein and the right hepatic vein. This is where you have deployed the stent. So this is where I have deployed the stent, right? So the minute I deploy the stent, what is going to happen? The blood that is flowing into the portal vein, The blood that is flowing into the portal vein with the help of stent will now directly go into the hepatic vein, from there into the IVC, and then into the right atria, right? So you're bypassing it. Now, obviously, when you bypass it, the volume of blood in the portal vein will decrease and the portal pressure will also reduce, and this is what we call it as TIPS. So what are the points that you have to write with respect to TIPS? Number one, in the TIPS, right, it is the right jugular vein. The right jugular vein is cannulated. It is cannulated with Roche needle. Okay. So the needle's name is important. So we have cannulated with Roche needle. Now once it is cannulated, the shunt is placed. It is placed between the right hepatic vein and the right portal vein. The right hepatic vein and the right portal vein, right? This is the concept of the TIPS that we have. Now once you have licked, what is the problem? Now we all know that the portal blood is rich in ammonia. It converts into urea in liver, it goes. But now what is going to happen? This ammonia rich blood is going to go. It is not going to liver, it is directly going into the circulation. So ammonia rich blood reaches into the circulation, resulting in encephalopathy. So the most common complication that is associated with TIPS, is going to be encephalopathy. It is going to be your encephalopathy, right? Hi Vishal, thank you. Right, so this is the component of TIPS that you have. Now, what are the other indications for TIPS? Where would you like to do? Other indication. The other indication for TIPS. Now talk about what are the other indications for TIPS. Number one, it is what we have discussed it now. That is your refractory variceal bleeding. That means we tried everything, all medical management, it didn't work, then you'll go with TIPS. Second, if there is presence of acute variceal bleeding, you can go to the algorithm. I have mentioned it there also. Acute variceal bleeding, there also you go ahead with TIPS. Then you have refractory ascites. Then you have the refractory ascites. Hepatic hydrothorax. Hepatic hydrothorax. Hepatorenal syndrome. Hepatorenal syndrome. Portal hypertensive gastropathy. Portal hypertensive gastropathy. Portal hypertensive gastropathy. Budd-Chiari syndrome. All these are the current indication for TIPS, right? So what are the other indication of TIPS? Remember all these points. Refractory variceal bleed, acute variceal bleed, refractory ascites, hepatic hydrothorax, hepatorenal syndrome, portal hypertensive gastropathy, Budd-Chiari syndrome. All these are the indications for TIPS. Okay. Now what are the indication बता दो, contraindication भी बताना चाहिए. What are the contraindication for TIPS? What are the contraindication for TIPS? What are the contraindication for TIPS? ठीक है. Currently, when you talk about the contraindication for TIPS, क्या क्या है हमारे पास? Number one, if there is a right-sided heart failure, obviously no. अगर राइट साइड का हार्ट काम नहीं करा ढंग से और आप ज़्यादा ब्लड दोगे तो ज़्यादा लोड दे रहे हो राइट साइड पे, तो पेशेंट हार्ट बोलेगा मेरे से नहीं होगा. ठीक है. सो राइट साइडेड हार्ट फेलियर. The right-sided heart failure. Pulmonary hypertension. Pulmonary hypertension. Hepatopulmonary syndrome. देखो हेपाटोरीनल सिंड्रोम के लिए इट्स एन इंडिकेशन. हेपाटोपल्मोनरी सिंड्रोम के लिए इट इज कॉन्ट्रा इंडिकेशन, क्योंकि हेपाटोपल्मोनरी सिंड्रोम विल रिजल्ट इन पल्मोनरी हाइपरटेंशन. पॉलीसिस्टिक लिवर डिजीज. पॉलीसिस्टिक लिवर डिजीज. polycystic liver disease, encephalopathy, portal vein thrombosis. Now already if there's a portal vein thrombosis, no, and you do if you put a shunt, what is going to happen? That thrombus is going to migrate, result in your embolism, right? It will result in pulmonary embolism. You don't want that to happen. So portal vein thrombosis or any hypervascular liver tumor. Any hypervascular liver tumor. If any one of them is present, it is a contraindication for TIPS. If you want to know even more, I can say the first 4 is an absolute contraindication. And the next 3 is your relative contraindication. Your relative contraindication. So that the indications and the contraindication for TIPS, this is what you write in your exam. If you're done with this, you're sorted. So if you look at the questions that we wanted to discuss today, did we complete them all? Let's look at the questions first. So did we complete tracheoesophageal fistula? We did. GERD done. Barrett's done. Esophageal varices done. TIPS done. Upper GI bleed and its management that we have discussed in the same context of your bleeding esophageal varices, your stepwise protocol, that is also discussed, right? So this concludes the current discussion for today's Farre. Thank you so much for joining. I'll be uploading the notes. If you have any questions, any queries, you know where to find me, you know where to ask. You can write it down on the Instagram channel, that is your surgery guy. Or you can also write it down. I mean, like, it's the same Telegram group also you have it. It is by my own name, that is Sandeep Reddy. Okay? Any questions, any queries, fire it away, right? Till then, thank you so much for joining. I hope the session was useful. The notes will be shared immediately. If you have any questions, any queries, do write to us, do ask us. We'll take it in. Please take the class tomorrow. Also, beta, tomorrow is my BLS. तो कल रात को BLS है. तो BLS is BLS. Okay. I don't know. I mean, there will be some other class scheduled for you. We'll try to do as many classes as possible before your university exam so that you revise your Farre and you go and you know what to expect it down from there. Until then, Vishal, thank you so much. I will try to accommodate if possible. Thank you so much for all the appreciation and the love. And for today, good night. Bye. Take care. Thank you.